Hello, my name is Dr. Davy, and this video is meant for students who are first starting their clinical rotation, and we'll be discussing the cardiovascular examination. So we'll break down the theory behind what we check and why it matters. No stethoscope is required, just your brain and maybe a little caffeine. Let's get started. So the learning outcome. By the end of this lecture, students should be able to demonstrate knowledge to perform a cardiovascular examination. This is for pediatrics. I'll make another video for adults. So the first thing that you do once you have your child, you introduce yourself to the patient and their guardian. Mostly it's the mother, and you ask permission to remove their clothes from the upper part of the body, and then you place them at an angle 45 degrees. Of course, you must make sure that you perform hygiene before you even touch the child, so you make sure that you wipe your hands with some alcohol. Once you position your child, the next thing you do is you perform a general inspection. So you observe the child from the end of the bed. So you stand at the very end of the bed and you start looking at the child. So the things that you look at, you look at if there are any dysmorphic features that would be suggestive of any congenital abnormalities like Down syndrome, Turner syndrome, Noonan syndromes. So some of the features you'll be looking at are like hyperpterylism, which are widely spaced eyes associated with Noonan syndrome, which can present with pulmonary valve stenosis. You're also going to look for micrognathia, which is a small jaw seen in conditions like Turner syndrome, which is associated with coarctation of the aorta. You're also going to look at low set ears, which can be present in Down syndrome and is associated with tetralogy of Fallot. You also look at conditions like pectus excavatum, which is a sunken chest, or pectus carinatum, which is a protruding chest, common in Marfan syndrome, which is associated with aortic root dilation and mitral valve prolapse. Some of the other things that you look at, also you look if there's a webbed neck suggestive of Turner syndrome, coarctation of the aorta, and so many other features that you just mention. If there are any abnormalities that you can notice from the end of the bed. You also check the nutritional status of the child. Do they look well nourished? Are they malnourished? You look if there's any cyanosis, if they have any blue discoloration. You look at the chest symmetry, if they're in any respiratory distress, are they struggling to breathe? You look if they have prefolic fascias, like the redness, that is redness of their face, or if there are any obvious scars. When you do that, now you perform a closer inspection. So you start with the upper limbs. So in the upper limbs, you inspect the hand for clubbing. So finger clubbing is when you lose the angle between the nail and the skin of the distal phalanx. You also check if there's palmar pallor, if there are splinter hemorrhages under the nail bed. These splinter hemorrhages would be suggestive of infective endocarditis. You can also check the toenails sometimes. You look at other features of infective endocarditis like Janeway lesions and Osler's nodes. So the difference between Janeway lesion and Osler's nodes is that Janeway lesions are painless, Osler's nodes are tender. and genuine lesions are usually flat. Osler's nodes are nodules, so you can actually feel a hard mass which is painful when you touch it. So this is a picture showing finger clubbing. You can see on the upper image that's showing the normal finger, where you have an angle between the nail bed and the skin. But in finger clubbing, you can see now it looks like a club. It's kind of clubbed. So it's the distal pharynx has widened, and also the nail is convex and thickened. You can see there's a loss of the angle between the nail bed and the skin, so it looks almost flat here. This is a picture of showing genuine lesions. So these are small, painless nodules on the sole of the patient with infective endocarditis. These are you can see the hemorrhages, the sphincter hemorrhages here. You can see some blood which has actually spilled here on the skin. It's in the nail bed, so that's suggestive of infective endocarditis. Now these are Osler's nodes. You can see it's red, and it's very painful when you touch it. So after inspection, so you were just looking at the patient. You are not touching the patient. Now you go to palpation, where you start touching the patient. So the things that you do, firstly, you feel for the pulses. So you feel for the radial pulse, you feel for the brachial pulse, and you can also feel both the radial and the femoral pulses at the same time. And notice if there's any delay between the radial pulse and the femoral pulse, because this can suggest coarctation of the aorta, where there's narrowing of the aorta, meaning that less blood is actually going down into the femoral artery. So the femoral pulse can feel less compared to the radial pulse. So when you're feeling for the pulse, it should, sometimes it might not even be present at all. So you have to make sure you can feel it, it's present, and you also note the rate, the rhythm. Is it a regular rhythm? Is it irregular? Is it irregularly? You also note the character of volume or amplitude, if it's bounding, full, or thready. Lift the arm to check for hyperdynamic pulsation, which can be present in aortic regurgitation, which we'll discuss in another video. You also measure the blood pressure in both upper limbs. So when you're feeling these things, it comes with experience. You need to know the normal and what is abnormal. So the physician should count the pulse rate and note if there are any irregularities in rate and volume. The normal pulse rate varies with the patient's age and status. So the younger the patient, the faster the pulse rate. Increased pulse rate may indicate excitement, fever, congestive heart failure, or arrhythmias. And if the pulse rate is slow, it may mean there's a heart block. It might be an effect of a drug. If there's irregularity in the pulse, it may suggest there are arrhythmias, but sinus arrhythmia is normal. And then you go to the head and neck. On inspection, you look at the conjunctiva. If there's pallor, which would suggest anemia. You also check if there's jaundice, which would suggest hemolysis due to artificial valves. Look in the mouth. You check under the tongue if there's cyanosis, that is bluish discoloration, which would suggest of hypoxia. You also check the teeth for dental hygiene, because when there's poor dental hygiene or caries, the patient is at a risk of subacute bacterial endocarditis. You also check the jugular venous pressure in an older child, because it's difficult to perform in a younger child, and the patient must be seated at 45 degrees, as because you already performing this exam while the child is seated at 45 degrees angle. And on palpation, with prior explanation, and you check if the trachea is central, but usually you leave this out for a respiratory examination. In a cardiovascular examination, you mostly feel for the carotid arteries if there's any fluid. Now you're done with the face and then the neck. Now you go to the chest. So on inspection, you check if there are any scars on the chest, if the chest is looking symmetrical, if you can notice a hyperactive podium, that is a chest that is bounding. You can actually see it beating sometimes. So if you see that, that would be it characterizes a heart disease with volume overload, such as that seen in defects with large left-right shunts, like in patent ductus arteriosus, or in ventricular septal defects, or heart disease with severe valvular regurgitation, e.g. aortic regurg, mitral regurgitation. Yeah, so you just note that. Next, after you inspect, then you pop the chest. So you feel for the apex position. So the apex is the most common position where you can actually feel your heartbeat. So you use the sternal angle as a guide. You count. So once you feel that apex beat, you have to locate it in terms of the position in terms of ribs. So you count at what rib it is. So as a landmark, you use the second intercostal space to help you locate the apex beat. So the second intercostal space is right at your sternal notch. If you remember from your anatomy that you did in basic medical sciences, at your manubrium, when you're sliding down your manubrium, you feel a bump, something like a ridge, that space, and then when you go to your left, that is your left second intercostal space. So you just count the spaces, you move down until you reach the place where you felt your apex beat. The normal apex beat is usually in the fifth intercostal space, mid-clavicular line. So the epical impulse is normally at the fifth intercostal space after the age of 7. Before this age, it's usually in the fourth intercostal space. An apical impulse is displaced laterally or downward when there's a cardiac enlargement. So you want to feel it in those spaces because the heart has gotten larger now. So you might end up feeling it in other places. After you do that, then you feel for thrills in all valvular areas. So you feel for the mitral valve, the aortic valve, tricuspid, as well as the pulmonary valves. So a thrill is more like it's more like a murmur, but you actually feel it with your hands and not with a stethoscope. So it's more like just a vibration that you feel. And then you feel for a heave. So a heave is when you actually place the heel of your hand on those valvular areas, and then you notice that your hand gets lifted up, it gets heaved up. So that could suggest pulmonary hypertension. Although, so we have done 3 things so far. We did the inspection, we did the palpation where we touched the patient, and now we auscultate. This is now when we start using our stethoscope. So you notice that we don't just go straight with a stethoscope to listen to the patient's heart. We have to go through each and every step to make sure we don't miss anything. So with the stethoscope, you listen in all valvular areas, starting with the apex. So you feel pulse to time, heart sounds, and additional sounds. Although ordinarily palpation follows inspection, auscultation may be more fruitful on a sleeping infant who might wake up and become uncooperative. The first sound that you hear, so when you're listening to the heart, you hear this lap dub. So the lap that you hear, it's due to closure of actually both the heart sound, the lab and the dub, is due to closure of valves. So the lab is due to closure of mitral and tricuspid valves. So it's the heart sound is due to closure of the pulmonary valves. Not for S1 and S2 intensities and whether S2 splits normally with respiration. So when you actually breathe in, you actually hear then listen for any other sounds. Roll to the left to assist with mitral murmurs. So for the murmurs, you have to make sure you characterize them in terms of site. So where is the murmur? Is it in the mitral area? Is it in the tricuspid area? Is it in the pulmonary area? Is it in the aortic area? And then you have to characterize them where, if they are radiating. So if it's a mitral murmur, usually radiates to the axilla. So you don't just listen to the mitral area, you also have to listen to the axilla to see if it's actually radiating there. If it's an aortic murmur, then you also have to listen if it's radiating to the carotid. So it can either radiate to the axilla, the neck, or the back, as in when you have coarctation of the aorta. The third thing, you also have to describe the time. Is it systolic, that is between S1 and 2? Is it diastolic, which is between S2 and S1? Or if it's just continuous? Or if it's an ejection systolic murmur? So you describe that. You also describe the intensity. So murmurs are graded. Systolic murmurs from 1 to 6, diastolic murmurs from 1 to 4. I'll take you through that in the subsequent slides. You also have to describe the character, if it's a harsh or high-pitched or blowing, because it will actually help you to know where that murmur is coming from, because if it's harsh, it's usually a ventricular septal defect. If it's high pitched or blowing, it's usually mitral regurg, or sometimes even VSD. Vibratily or humming, these are usually innocent murmurs. So for the grading, as I said, for the systolic murmurs is from 1 to 6. For grade 1 is barely audible. Grade 2 is soft but easily audible. Grade 3, it's moderately loud but not accompanied by a thrill. Grade 4 is louder and usually associated with a 3. So remember what I said about thrills, like you feel these vibratory sensations by just touching that area, and you can actually feel a vibration without even putting a stethoscope on. And grade 5 is audible with a stethoscope barely on the chest. So you just put like the part of the stethoscope, not putting it entirely on the patient's head, but you can still hear that murmur. But grade 6 is audible even without a stethoscope. Like you can put it at a distance and you'll be able to hear the murmur. So it's very, very, very loud. Now tilt the patient, listen over the back for radiation of murmurs, inspiratory crackles, especially the bases with left cardiac failure, for sacral edema. So you don't just auscultate the heart, you also actually have to auscultate the bases of the lungs, because when a patient has left cardiac failure, sometimes it causes what we call pulmonary hypertension, where the blood fails to actually get into the heart, because the heart is failing, obviously. So it actually backs up into the lungs, creating so much pressure, and some of the fluids start leaking into the lung tissue, and then it creates what we call pulmonary edema. And when you're breathing, because there's fluid in those lungs, when you listen to the lung bases, you hear what we call crackles. So that's why it's important to actually also auscultate the lung bases, because it can actually help you to actually know if the patient also has cardiac failure. So for the locations of the systolic murmurs, at the left upper sternal border, you can listen for pulmonary valve stenosis, atrioseptal defect, coarctation of the aorta, and patent ductus arteriosus. At the left lower sternal border, you can listen for ventricular septal defects, tricuspid regurgitation. At the apex pit, usually it's the mitral regurgitation. At the right upper sternal border, it's the aortic valve stenosis usually. And then you also go to the abdomen. You palpate the liver, because in congestive cardiac failure, usually the liver gets enlarged, so you have to palpate it to rule that out. And you also can check if the liver is pulsatile in a case of tricuspid incompetence. You also check for splenomegaly if the spleen is enlarged. Yeah, because it can also occur in the same condition. Usually when the liver is enlarged, the spleen also enlarges due to what we call hepatic, when there's hypertension, like in the blood vessels in the liver. In the lower limbs, you can also check for the same things, clubbing, splinter hemorrhages, and you also just check if there's edema, that is, if fluid has actually accumulated in the lower limbs, which would be suggestive of congestive heart failure, most especially, the right heart failure. and not routinely done. This can only be done in certain situations. You can check the eyes using an ophthalmoscope for rough spots, which usually suggests damage of the capillaries in your the blood vessels in your eyes, especially when there's hypertension. No, not hypertension. This is usually in infective endocarditis, when you have these rough spots. So you can actually, if you're not an expert at this, maybe you can even call the ophthalmologist to help you determine if there are rough spots. Any questions so far? If you have any questions, please drop them in the comment section. So as I said, this was a 2-part video, and I'll be posting on the congenital structural lesions in children in the next video that I'm making. So thank you so much for watching, and see you in the next one.